Good afternoon, everyone. My name is Dayajani Jaquette. I am a LULAC fellow, and I'll be introducing our moderator for the next session. Dr. Ray Serrano is LULAC's Director of Research and Policy. He expands the organization's role by integrating robust research to better serve the Latino community. He was raised in Idaho as the son of migrant farm workers. Dr. Serrano's journey showcases dedication and resilience. His academic path includes Stanford for his bachelor's, Yale for his master's in public health, and Emory University for his PhD. Notable fellowships like the Laney Graduate School and Ford Foundation underscore his commitment to transformative health policy. With diverse professional experiences, including roles at the WHO, CMS, and UNDP, Dr. Serrano has been instrumental in shaping healthcare policies and improving services for marginalized communities. Please welcome Dr. Ray Serrano.
Thank you, Dianjane. Can everybody hear me? All right. So I know it's this panel before lunch, so I'm going to try to, we'll make it exciting and brief, but I have an amazing panel here. Really, I think of this panel as a panel of pioneers. I think these folks are absolutely very impressive folks. I'll start out just a quick introduction of, so the topic is on obesity. Ironically me, right? No, the topic is on obesity and the social determinants of health. And if you guys have not focused on like this, so what are the conditions that are upstream that cause people to be sick? Is it the environment? Is it the nutrition? Is it the information, the culture, the economy, whatever? Like all those issues that matter downstream in terms of what our health is. Again, our panel of pioneers, I want to first start off introducing Dr. Elena Rios. Dr. Rios is the, sorry, I have my note, I can't read these here, so I'm going to read my notes. Dr. Elena Rios is the president and CEO of the National Hispanic Medical Association. She represents a coalition of 50,000 Latino physicians, which, by the way, includes my sister, and so who's an OBGYN in El Paso. And so Dr. Rios has just a wealth of knowledge and a wealth of experience working in this area as a clinician, and someone also has anywhere. So the second panelist we have is Dr. Eliseo Perez-Stable. He might have the title of being the busiest man here in DC. He works at the National Institute of Health. He's the director of the National Institute on Minority Health and Health Disparities. The work that they do at the National Institutes of Health, and particularly the work at the National Institute of Health and Minority Health and Health Disparities, is incredible. I mean, they guide policy. They really do delve into the research to really inform what we know. And it's an incredible amount. So and then last but not least, Dr. Yanira Cruz, another pioneer, president and CEO of the National Hispanic Council on Aging. Dr. Cruz is the Latino voice when it comes to aging. She really gets it. She's a clinician. She's actually a background in public health, and she understands this issue very well. And again, our three panelists of pioneers, folks who are really, we all stand on I stand on their shoulders of the work that they've done to open the doors for a lot of us. But to give you some background of this topic, so I'm going to go a little bit personal. So the issue of obesity, I guess the question constantly is, what is the cause? Where, and then from that as a cause, what is the prescription? What is the solution for it? So when we started talking about the topic, I immediately thought about my mom. So as Dianjane mentioned, I come from a family of migrant farm workers. I grew up in Idaho. No applause from anybody from Idaho. one person? Okay, there we go. Yeah, Dad from Michoacan, Mexico, undocumented, married mom from South Texas. They kind of traveled around the country working, following crop harvests. My mom was one of the hardest working people I knew. She passed away a few years ago, but she worked 2 jobs. She was the oldest of 12. She had 50 days of schooling. She worked 2 jobs for most of my life, where basically from 6 in the morning to 2 p.m., and then came back home, showered, and then from 3 p.m. to 11 p.m. every single day. By the time she was in her 50s, late 50s, Mom's weight got really, really bad. She was about 535 pounds. And with that came hypertension, diabetes, the knee replacement, congestive heart failure. We joked that she was the $1 million patient. With all her conditions, to treat all those conditions, she was the $1 million patient. I was around 21 at the time when a physician, Serrano is not a very common last name in Idaho, and he says, Ray Serrano. He's like, are you related to Maria? I'm like, yeah. And he's like, oh boy, your mom, she's in really bad shape. I don't give her longer than a year to live. And so it got me thinking. At the time, I get sucked to know that. But it also got me thinking a lot about, this doctor doesn't get it. It's not like my mom is lazy. He just doesn't get it. She's a hardworking person. She's probably the hardest working person I know. What caused this? How did we get here? Is it the food? Is it the diet? Is it the culture? Is it the amount of work? Where did we get at this level? And then from that, how do we solve this problem? Because we shouldn't be here. And then to give you one last haunting statistic, 46% of Latino adults are obese. That's about half. 46%. It's higher than any other group. This issue is squarely our issue. And so it matters a lot to us to think about this issue a lot. It's not about so much, obviously it's about diet, but it's an issue that affects a lot of us, indirectly or directly. So again, I'll stop talking. I'm going to turn it over to our great panelists here. And so again, this is kind of just a format of just kind of a informal dialogue to really kind of just talk about your work and how we go from here.
Maybe I'll start us. So you say, what's the cause of obesity? It's complex. If you look back in history, people who had more resources or wealthier people would usually be the ones that tended towards increased weight. That's completely changed. So there is a big social class component. So when that happens, you start thinking, well, what's the structural factors that lead to that? Nowadays, when you see 46%, you see that go down when the head of household gets a college education. But the benefit that Latinos or blacks derive from that improvement in socioeconomic status is lower than what you see for other populations. So I think that's the first thing to think about. Another issue on the structure is access to healthy food. It's a lot easier and cheaper to buy ultra-processed, caloric-dense food than it is to cook or to buy real food, whether it be fresh fruits and vegetables or unprocessed or less processed food. It takes a little bit of effort. And over time, those extra calories build up. One does not become obese or excess weight, if you wish, because, oh, I didn't do enough physical activity or I didn't do my exercise. That's what sometimes it's you eat too much. And another structural component is the food industry. We live in a country where we get 3,000 calories per day produced per person in the U.S. And we need between 1,500 and 1,800 calories per day to be fine. So you do the math. How much extra food is offered to everyone in this country by industry? And of course, the easy one is, the ultra-processed, inexpensive food, and I think those are important.
So, I think it's on. Okay. Very good point. I think one issue that we face a lot, as I mentioned about in my mom's case, like we have providers that know, and that you have a population that is kind of, a lot of Latinos, we kind of tiptoe to the doctor's office, and whatever the doctor says to us, we kind of take it at face value. But a lot of times the doctor doesn't quite look like us. He doesn't come from our community. He doesn't quite know us. Why should it matter that doctors know us? Like, so I'm going to turn it to Dr. Rios to ask that the question of.
Yeah, I think the importance of having doctors and nurses and all healthcare workers be part of the community is to be able to have better communication skills. And you can't take a history and physical of a patient without talking to them and understanding that the patient will be, in a little bit of a what they call white coat shock, not wanting to talk, and not ask questions. And so to have a real dialogue between the providers or the clinicians and the patient, it does make a difference to have the same, to be familiar enough with the patient to know how they live, where they go to the grocery store, since we're talking about food and nutrition, and know the challenges of working 2 jobs or working in low-income jobs, and trying to provide some comfort in understanding and respect, and I would just say real trust that the patient will then open up more and talk about real issues, not just superficial issues, or here's a paper to go read on what you should eat, instead of talking about how you can better cook your food, using less oils and, using olive oil instead of just Wesson oil or what have you, and corn tortillas instead of flour tortillas, and, and how beans is really good for you because they're protein, and, not everybody can afford all the big steaks and meat and fish, but I think what's important is that you have an understanding of how the patient and family lives, and that's why it's so important. So I'll just stop there, but I think there's a lot to talk about.
So one of the greatest examples I saw in Georgia, it was a doctor from Mexico who worked at a kind of clinic that predominantly served Latinos, and she would do cooking classes. She had a whole kitchen set up at the clinic where she had classes that she would bring in Latino women to teach them how to cook healthier. And just make very simple interventions like that. I think it was a very smart way of getting, and fun way of teaching information to folks and as opposed to just simply handing them a piece of literature and saying, hey, do this. Dr. Cruz, so again, the issue of obesity, unfortunately we are seeing it in child obesity, but particularly in aging. Latinos, unfortunately, like if you look at the trajectory of our life expectancy is actually dropping in some ways, and so, but aging is becoming, but we see it Latinos, life expectancy for over generations is dropping, but Latinos in elderly, like you see a wide set of chronic conditions. What particularly makes Latinos so different than African Americans or white?
Thank you. Thanks for that question, Ray. And it's great to be here. So at the National Hispanic Council on Aging, where we work to improve the lives of Hispanic older adults and their caregivers, we monitor these issues. And first of all, I think Latinos age with a number of disadvantages as compared to the rest of the population. First, many Latinos work in the service industry, for example, and construction. And so very demanding, physically demanding jobs, right? By the time they age, they, you know, they age with many chronic illnesses, and, you know, oftentimes age with a fixed income. And what do I mean by that? I mean a typical income for an older adult who lives at our housing facility, which is down the street from here at Casa Iris on 12th and W, is about $700 a month. And there's very little you can do with $700. You know, once you make expenses for food, you know, if you drive and you have a car and you pay insurance, and you pay for some medications, you really are left with barely enough to get your hair cut for the month. And those are the realities that face many Hispanic seniors in the United States today. That puts them in a very difficult situation and very different than the rest of the country as they're aging. In addition to that, the digital divide, right? We live in a digital world. Most of you are now connected through this little thing here, a smartphone. And for many older adults, that is just not the case. Some of them may have a phone, but oftentimes don't know how to use it. Many don't have an email address. And if you will recall, during the pandemic, in order to get a vaccine, it was required that we have an email address. So Latino seniors were left out in the dark because they couldn't sign up to get vaccinated at the beginning of the pandemic. Eventually that changed and there was more access. But the digital divide remains, and that leads many of our folks out of information, out of timely information, the lack of awareness on the new science, new knowledge. Just information in general is not readily available for many of our Latino older adults. So, you know, and then the health literacy level, it's also very limited. And a lot has to do with the fact that our older adults have aged with limited education because of the many challenges they faced, you know, in their adult years. So those are some examples, Ray, that I can think of.
No, definitely. You touched a little bit about, Dr. Cruz and I think touched a little bit about the issue. I was going to ask Dr. Perez, the issue of acculturation. So a lot of Latinos are kind of born outside the country, kind of come into the country. I was joking earlier about how mom would, before she would go to work, she'd prepare a pot of nopales. and I was like, we don't want to eat nopales. We want to eat mac and cheese. We want to eat something else. We don't like, and so eventually mom gave up on cooking nopales and hoping that we were going to eat nopales. So we decided she was going to, so she just started eating mac and cheese too. So that in some ways, like our diet, our poor health choices, because we were American, right? We were born in Idaho, kind of became her health choices. And so in some ways, like, so how can we address the issue of acculturation and health?
So, great question. I would say this has been a point of discussion amongst researchers working in Latino health since my whole career. So, there's a general belief that as you acculturate as a Latino, you're going to adopt the habits of the dominant culture, the U.S., and get less healthy. But keep in mind that 70% of Latinos living in the United States today were born in the United States. So we are no longer an immigrant population like we used to be. There is the second and third generation. You know, I was born in Cuba myself. My sons were born in California. So, and this interaction of what's tradition, what's the language use, because whether you maintain Spanish as a marker of acculturation or not, that's been an important one. And harder to study is the diets and other, the family dynamics is another thing that has come, or community cohesion. These are all factors that researchers have tried to evaluate to explain what we see in health outcomes for Latinos. Earlier, I think Elena mentioned sort of traditional diet. So one of the most valuable things of almost universal in Latin America, not entirely, but almost, is eating beans, pulses. These are very nutritious, highly valued nutrition that we lose the habit of eating beans over time. It's true in Mexico, it's true for the Caribbean Latinos, it's true for many Central American and South American countries as well. And that influences metabolic syndrome, whether you get diabetes or not. Obviously, it's a dynamic that needs to be factored in. And again, the more processed the food, the worse it is for you, no matter how good it tastes. and that's where you say, well, I can have a little bit, yeah, probably okay, but you really have to look at a balance over time that really allows for maintaining traditional foods that are really valuable, as well as selecting foods that are good. At the institute I direct, the National Institute on Minority Health and Health Disparities, we funded a grant in the Southwest, I forget which state, where they used a traditional diet to try to reverse, and somewhat successfully, changes in the liver from fatty infiltration. Fat infiltrates the liver, causes inflammation, and it causes a disease called non-alcoholic hepatic steatosis. So it inflames the liver, which can, in some people, lead to liver failure and cancer. So it's an important consequence of obesity that it doesn't get as much attention as diabetes and heart disease, but it's also important. And here we are, an intervention with a traditional diet that can make it better. So,
yeah, thank you. No, I think, Dr. Rios, I saw in your bio mention about Better Medicare Alliance, and I was curious to know. I used to work at Center for Medicare, and I was curious. One of the issues right now on obesity control is the anti-obesity medications. You probably have heard in the news about Ozempic and Mounjaro and something, all these a lot of the anti-diabetes medications. Where are we on that as a tool that could be used to combat obesity?
Well, I think what's happened about these new medications is insurance companies are looking at them and covering some insurance companies. So not all. They are new and they are expensive. There's also an issue of what their label is for. So these medications are for diabetics, for example, or pre-diabetics, so you have to have a diagnosis before you can be eligible to get them. And I know the FDA changed at least one of them to be for obesity patients, for obese patients. But the big issue right now is that there's a whole movement to have people that are over 65. When you're 65 years old in this country, you're eligible for Medicare insurance. It's another insurance company, another insurance program. I'll say half the people are on government-paid Medicare, and half the people are on what's called Medicare Advantage. And for Latinos, actually, most Latinos, there are more Latinos on Medicare Advantage than on just regular Medicare. Medicare Advantage is a public-private partnership where private companies, private insurance companies help pay the bill, and they take the risk. And but it doesn't matter which Medicare you're on, the federal government or the public-private Medicare, they do not cover these medications at all. So if the issue for us as the National Hispanic Medical Association here in Washington tries to do policies focused on how to improve our community's health. And we look at Republican and Democrat congressmen, senators, the same. We're just saying, well, do you have Hispanics in in your neighborhoods? Do you have hospitals? Do you have medical schools? How can we be of service to teach you about policies that would be important to our communities? So this is one example. So if you're an insured person working and you have insurance that pays for these medications, the anti-obesity medications, whatever the name is, we don't care about names and brands so much. But as soon as, and your insurance company pays for it, right? But as soon as you turn 65 and you go to Medicare, you can't get it anymore. So there's policies being discussed, and there's a TROA Act, the Treatment to Reduce Obesity Act, that has been introduced in Congress a few times now. It hasn't been able to get the number of votes needed to be approved, but we support it, and others support the fact that Medicare should cover. And get this, the veterans insurance companies cover these medications, and so does the insurance companies for the federal government employees. So all the congressmen, they can get it, but the people that are not veterans and not working for the federal government that turn 65 and have Medicare cannot get insured coverage of these anti-obesity medications. Yeah. And that's another just form of why is that? And it may be, well, it may be too expensive for the government to cover. It may be just that they haven't done enough research to make sure that there's not going to be a lot of problems with these medications. And so far, the research has just shown that most people don't have many problems with the medications. I think the worst problem that's happened is these medications tend to stop your appetite, decrease your appetite, decrease your metabolism, and so your gut, your intestines tend to slow down. And some people, and very few, and every medication has side effects, but very few have had problems with I'll just say a frozen gut or a slowed down gut where you stop eating, and that's why you lose weight. But once you stop the medication, you may not pick up the metabolism to the natural rates. Yeah. But at any rate, that's part of the policy issues around these new medications. And there's always policy changes that have to happen when you have new products in the market. And in this case, it's about obesity and trying to decrease obesity.
No, very, very good.
If I could add, just add to Dr. Rios' comments, many of the older adults, actually all the older adults that we serve, actually fall in the category where there's no access to the medications that are available to control obesity. So, and I think that is a leading cause for older adults to not lose weight, to disparities, more disparities, right? So, just wanted to point that out.
Many of you tomorrow are going to go to the Hill and talk to different congressmen. And sometimes you will get some questions like, how much is it going to cost? And I think I will say, for me, the way I interpret policy is it's not so much the cost of action as opposed to the cost of inaction. Mm-hmm. If you don't, there is a cost. You're going to pay for it now, or you're going to pay for it later. Because if you don't do the interventions now, later, again, I gave the example of my mother, who was $1 million patient, because she was unmedicated, she was on Medicare, all her health conditions, they were paid out, and they were very expensive. So we only have a few minutes left here. I wanted to just kind of ask, just kind of closing remarks from each of you, on where do we go from here? Because it's such a complex issue. I mean, obviously there's different actors. There's the food environment, there's the kind of the planning, planning and zoning of, like, you hear about food deserts and fast food swamps. There's the health health literacy, how people perceived health, the stigma we didn't get a chance to touch upon, but the stigma of folks who are obese or at risk of obesity, particularly for Latino men who are least likely to go into the healthcare setting, and then providers who oftentimes are not Latino. And so all of these factors, so where do we go from here? So, sorry, big huge question to ask, but I'm going to turn it over to you.
I'll get us started. All those issues are critical. You mentioned cost. We did a study through a contract that showed that the cost of health disparities by race and ethnicity in this country is estimated to be $450 billion per year. And Latinos who have a lower mortality than people would expect, their excess costs come from health services and time lost from work, predominantly, not exclusively. So your point about that is huge. And if we only invested 10% of that into programs to improve or decrease disparities, we would really be much better off. Taxes is another way we can structurally change things. We funded a grant in Navajo Nation where they added a junk food tax of 6% and took away any tax on water and food. They have been able to reinvest some of that into health programs. Whether or not they'll impact the health of the Navajo Nation, we'll see. That's to be determined, but I think that's another measure. Mexico has done tremendous work with sweetened beverage taxes and decreasing. They have the highest rate in Mexico. Has the highest rate of diabetes in the world. That didn't used to be true, and now through some of these structural interventions, we can see benefit. And finally, in the context of clinical care, you have to have behavior change. You don't get to lose weight without eating less, and that means you have to modify your behavior. Yes, a pill might help. There are other things that help, including surgery for more extreme cases. And surgery is actually pretty good, and it works, and it's not that invasive, and we underuse it. And so those are the things that I would leave you with. Thanks.
Yeah, I just add to that. I think that the stigma issue is really important. And people need to realize, you need to tell your friends and parents that it's not your fault. We have so many barriers in our society of why people can't get good food, nutritious food, or like we said, you're tired and you just want to have some ice cream at night or something, And we need to understand, though, that you can help yourself and you can help others by being aware of what you eat and drink, and sodas is really bad, and you get addicted. You don't realize how much you get addicted to sodas, and not only that, but you need to understand how to eat better, and maybe eating smaller portions, eating vegetables, eating a balanced diet where you have and we have a lot of government programs, and Latinos don't apply for the government programs, and you should. We have free food for school children, and during the pandemic, the food was for the whole families, and I think that should be brought back. The idea of having nutritious food that are part of our school meal programs, and even during the summer when school's not in session. And there are some cities now and states that are actually not requiring, but taking advantage of the opportunity. It's an opportunity for all kids in the schools to get the good, nutritious meal programs, instead of being stigmatized that those are just poor kids, right? And the other thing is we have meal programs for seniors too. The Meals on Wheels programs are for seniors. We have senior centers in our communities that offer daycare for seniors and food. And the other government program that's really important is WIC, Women, Infant, and Children. And it's really important, especially for, women that are pregnant that need to eat better and eat more. I think it's important to realize that, and for whatever the reason is, either it's a language issue, it's the applications are too complex, we have barriers of just applying for programs that are made for all of us, for all Americans.
Very, very good point. I think Dr. Cruz, I'm getting told it, but go. Would you want to provide a few remarks?
Yeah, I'll just add that women play an important role in our families, and that as we work to change behavior, educate our families on what's healthy for us, I think it's important that we have targeted efforts at women. Of course, not leaving out men, but women are pillars in our families, and they are major decision makers. So I think to the extent that we can empower women with the right information, I think we will go a long way. There's also an obesity bill of rights that was recently created by the National Council on Aging, and I think organizations like the National Hispanic Medical Associations have signed on, the National Council on Aging have also signed on, and 40 other organizations. And essentially, this is a document that says, this is what we need in order to address obesity for women, for children, for older adults, for general, and I invite you to find the Obesity Bill of Rights, particularly as you go and meet with Congress today or tomorrow. This way you have another tool that can help you as you do advocacy. And don't forget, your voice is power. And you do have a representative on Capitol Hill, and use that. Use that to make change. Use that to inform and educate your representatives. And tomorrow is a perfect opportunity to do that.
Great. No, very valid points all across. I think, again, it starts with all of us, right? We are all, there is no other leaders in this. It's Latinos, us, ourselves, who have to take charge and really kind of force our voice, make sure that our voice is represented at the table, the way that healthcare is distributed. We need more public health folks. We need more doctors. We need more people who could be talking about these issues. And again, just to conclude on my mom's story, before she passed away, she did adhere to a very strict regimen. My sister's a medical doctor, so her big thing was like, you're not going to eat that. You're not going to do this. I mean, she was checking nutritional labels on stuff. She had lost probably about, I want to say 280 pounds before she passed away. It was a new mom. So it was a great story. And I can think of that intervention of just being a very strict diet and having my sister forcing her to walk, that got us a few more years of her to be able to fly around and to kind of live life. And so I will say that there is hope, but I do think that there's a lot of challenges facing our particular community. I think it's important for each one of us to recognize that health is not just the clinic, it's before the clinic. So thank you.